Hi, this is Jocelyn Strand. I'm a naturopathic doctor from northern Minnesota and the director of clinical education for Botanical Research. As you may know, we were originally going to have Dr. Beth Rossellini, who's a dentist in the Dallas area, do this webinar for us, but due to personal reasons, she wasn't able to do that, and we certainly wish her well. Hopefully, I can bring forward some clinically relevant information for you related to oral health and GI and systemic health. I want to just first start out by saying I wish everybody health and well-being during this time, and I want to thank EHS for providing a platform for us to connect and learn from one another in the current climate. So without further ado, the oral microbiome and the impacts on systemic health. So let's set the stage a little bit first by just talking about the basics of oral health. It was news to me when I did the research last fall that about 77% or up to 77% of American adults over 30 years old have some degree of periodontitis. I have never seen or paid much attention to it in my practice before this time, before I learned that. And what it does is make it very clear that there's an urgent need to address oral health as a part of our clinical practice. Identifying causative factors becomes very important. So poor diet, and that means diets high in refined carbohydrates, smoking, alcohol use, pregnancy, immune suppression. These are all well-established risk factors for periodontal disease. So if you have a patient like that walk through your door, then it would be good to just to make sure and evaluate their oral health as well. So there are over 700 of species of just bacteria in the mouth with a mean of about 296 microorganisms. You pair that with the fact that we swallow a liter or more of saliva, and that every milliliter of saliva has 10 to the 8th microorganisms, and it makes it really clear that paying attention to what is growing in the mouth is also a potential risk factor or support for health in the oral area, and not only that, but gastrointestinal because of translocation, and systemic as well. So microbial diversity, very important. And here are some microbes of note in the mouth. This is a very small snapshot, but just gives you an idea of some of what we're looking at. And these are microorganisms that are also renowned in the literature and in the research for contributing to pathogenesis in the body. So bacteria will be a mix of commensals, symbionts, and pathogens. Some of the notable bugs are Porphyromonas gingivalis. I would put Porphyromonas endodontalis as well in this group. One of the most common microorganisms associated with periodontitis and systemic illnesses, including Alzheimer's at this point. Streptococcus mutans is one of the, along with Candida, one of the two main players in the production of plaque, which is biofilm in the mouth. Treponema denticola is a main etiological bacteria of periodontitis as well. And then we also have viral, I already talked about the fungal, so I'll skip over that. But I guess also add in that the fungal or Candida albicans, of course, can cause thrush, but it's also connected to GI infection and can cause disseminated systemic illness as well. So viral infection can be HPV and CMV in the mouth, and those contribute to oropharyngeal cancers, esophagitis, gastritis, enteritis, and colitis. So these are all microorganisms to pay attention to. So because of the anatomy of the mouth, there are a number of different habitats. So the microbiome shifts between different body sites in general, and that's due to prevailing properties of the local area. This is called the ecological niche. And in the mouth, there are a number of different ecological niche. So I find that fascinating that we have an example be on the tongue. In the rugae of the tongue, we have microorganisms that participate in the nitric oxide cycle, and therefore can contribute or help prevent cardiovascular disease potentially. So I think Neisseria is one of those, but right now it's being studied quite extensively whether I guess what was shown is in research is that chlorhexidine or other antibiotics, things that antiseptics that completely wipe out the flora in the mouth, that they can cause a transient increase in blood pressure. They can also prevent the benefits of exercise if you are using something like the chlorhexidine rinse in the mouth. And so we are actually evaluating that right now with our product line. We haven't got it yet, but stay tuned for data on how the use of the oral healthcare line from Biobotanical Research affects or does not affect the blood pressure and nitric oxide in the mouth. So moving along, we can see the gingival sulcus, attached gingiva, the cheek, the lip, the hard and the soft palate, and the teeth. And the teeth are really important players in the oral microbiome as the only non-shedding surface, and they do, because of that, provide a place where biofilms can establish and maintain themselves, and we'll talk about that in depth. This is an article published recently that shows that people who brush after meals had a resultant dramatic reduction in levels of Candida albicans, and you can see on the graphs here that there's it swings down the number of microorganisms in the stool after if people brush more frequently. So the conclusions of the study were that it suggests that the oral cavity may be the primary source of Candida albicans detected in the stool of healthy people. Indeed, fungal component of dental plaque of at least one cohort has been shown to be dominated by Candida albicans. Taking additional measures to further reduce oral Candida albicans levels, such as extra flossing and attention to elimination of plaque and reduction of consumption of refined sugars, and I would postulate to using healthy antimicrobial microbials in your oral health or in your oral hygiene routine may reduce the Candida albicans even sooner or even further. This is exciting because I think we can pretty easily extrapolate this to other microorganisms in the mouth as well, that if we can keep the microbiome in the mouth in healthy balance, keep those pathogens in check, that we can help establish good gastrointestinal function. And I should say it this way, help establish healthy microbiome balance in the gastrointestinal tract. And the nice thing about this is that it's a relatively easy place for us to direct a therapeutic is using toothpaste or oral rinse. It's not another supplement to take. It's something people are already doing. And so we can see here that we would expect that if we can restore balance in the oral microbiome, that we that would extend to the gastrointestinal tract. Here's a list, or just 4 different articles showing that there are a number of bacteria in the mouth that colonize the mouth that are implicated routinely in SIBO. So methanogens, Campylobacter. I pulled that article because Mark Pimentel talks about about an acute food poisoning event being one of the main, or maybe the main cause of SIBO, where it overlaps with IBSD and IBSM. And oral Campylobacter, Campylobacter infection is the most common cause of foodborne illness. Staphylococcus aureus, you can see here, and also oral streptococci. So all of these microorganisms play a role in SIBO and do exist in the mouth as well. So again, establishing the importance of maintaining a healthy oral microbiome. So these are biofilms on a toothbrush bristle and then higher magnification of that same biofilm. I like to think that my biofilm my toothbrush doesn't look like this because I'm using the dental Sidon toothpaste, but I guess I would have to take it into a lab to see for sure. Let's talk a little bit about oral biofilms and why that happens and why it's so important to know about. So again, the non-shedding nature of the teeth makes it a place where microorganisms can set up camp and the surface isn't shed repeatedly. So that includes the surfaces of the teeth, but also important are the pits and the fissures, places where you can't necessarily get your toothbrush. And so what this does is enable, when you have a biofilm, then it can spontaneously rupture and re-inoculate the mouth, can again re-inoculate and translocate into the gastrointestinal tract. If it's not removed, then it can be a source of incipient dysbiosis. I'd like to take a minute just to talk about the pathogenesis of biofilms and how it relates to periodontitis, and then the larger picture of systemic illness as well. So neutrophils are our primary immune defense in the mouth, but they are not active against or effective against biofilm-associated bacteria. So you get, and yeast, so if you get a biofilm down adjacent to the gingiva, and just you can see in that first sort of on the left-hand side that initially there's healthy tissue there. But if a biofilm develops there and you're not addressing it, then it becomes, the neutrophils come in. As they attack the biofilms, they'll set off an inflammatory cascade that can develop into a gingivitis lesion. And then our body responds by increasing infiltration of T cells and macrophages. And then the gingivitis can progress into, it damages the tissue in the area, and it can progress into periodontitis or periodontal disease, that characteristic periodontal pocket, and then destruction of the surrounding tissue. And that's when you end up, its proximity to the blood flow in that area is so close that you can end up with a number of different mechanisms for pathogenesis. In the bottom 3 bullet points you can see here, so you can have actual spread of infection or translocation and bacteremia directly from the periodontal pocket. You can also get then an increase in oral microbial toxins, so a flow of toxins, endotoxins and exotoxins from the mouth directly into the bloodstream. And it also causes this increase in inflammation and immunological injury will result in elevated LPS and other pro-inflammatory cytokines. And you can see here too, on the top bullet point, 500 species of microbes have been isolated from periodontal disease patients less than 1 minute after an oral procedure. And it is again because of that proximity of the blood flow in the periodontal pocket. Those organisms from the infected site, less than 1 minute after an oral procedure, organisms from the infected site may have reached the heart, the lungs, and the peripheral capillary system. So we have, not only do we have translocation of pathogens from the mouth to the gut, but we have this direct translocation into the bloodstream causing bacteremia. We have increase in toxic load and endotoxemia with the toxic byproducts of the sort of the interplay between our immune system and the microorganisms. And this is illustrates it more eloquently, right, than what I was saying, which is due to the anatomical proximity of the periodontal biofilm to the gingival bloodstream. Periodontal pockets may act as reservoirs of microbial pathogens and their products, as well as inflammatory mediators and immunocomplexes that can disseminate to other sites of the body. I should have just come and read that. It would have saved everybody a little bit of time, but a nice way to put it concisely. So this is an illustration of how transient bacteremia can happen and the resulting cascade of events. So I'm not going to spend much time here because we've talked so much about it already, but you can see dental carie, periapical abscess, periodontitis, and gingivitis all can result in this sort of bacteremia, which can be related to endocarditis, pericarditis, and a lot of this due, again, to that chronic inflammatory response initiated there. Here are a number of systemic illnesses and diseases that are related to oral bacteremia, or oral bacteria, excuse me. CVD and stroke, rheumatoid arthritis, adverse pregnancy outcomes, inflammatory bowel disease, and colorectal cancer, respiratory tract infections, meningitis or brain abscesses, lung, liver, or splenic abscess, appendicitis, pneumonia, and diabetes. So this is, again, a snapshot. It's not exhaustive in the literature. Here's another list, and I'll leave you to look through these on your own. But again, well-established oral systemic link here. This is a study with 1,676 subjects, and what I like about this is that it was for 30 years that they tracked these people, and people with a higher plaque index, which they consider a marker of poor oral hygiene. I think all of us know that it's not necessarily the only role that's being played there, that sometimes there are genetics, and people with excellent oral hygiene can also have these illnesses. But those people who had that marker of higher plaque index were more likely to develop autoimmune disease over the course of that 30 years. So periodontal disease, again, in its relationship to cardiovascular disease, one study showed that undetected tooth infections could increase the risk of heart disease by almost 3 times. So this was research published in the Journal of Dental Research, that they are 2.7 times more likely to have coronary artery disease than patients who have had treatment of those dental infections. And this, again, another relatively recent publication showing that the two different mechanisms of action for the oral microbiome to contribute to systemic illness. The one is this microbial shift disease directly from the mouth into the bloodstream via the periodontal pocket and the circulation there, or and then the other is this translocation of the oral microbiome into the gastrointestinal tract, and that if there are pathogens there, that can cause damage to the gastrointestinal lining, endotoxemia, and the resultant cascade that we all know pretty well there, right? So I think of damage to the mucosal lining, the increase in pathogens and LPS, TMAO, and the translocation of those metabolites into the bloodstream, circulating, causing increased chronic inflammation, damaging the blood-brain barrier, and potentially causing damage to the blood-brain barrier and contributing to brain illnesses as well. So we have on this list atherosclerosis, diabetes, rheumatoid arthritis, cancer, non-alcoholic fatty liver disease, and obesity, all that could be potentially tied back to the oral microbiome. And I just love this slide because I think it's very useful for us as clinicians to be able to, this is a slide that I even would consider keeping in my office, but that modest inflammation and the progression, so dysbiotic biofilm leading to a periodontal pocket, inflammation of the gingiva, and that the release of toxins, and this is called microbial shift disease, when the toxic sort of milieu, or however you say that, is sitting there in the periodontal pocket, and it's creating an ongoing source of toxic load that damages the mucosa, and then that results in this damage to the systemic, the whole system. So biofilms, the reason I use this slide is because as a clinician, I think it's really important to keep in mind that when you're working actively with biofilms, that patients may need some additional support, and they may have a reaction to the breakdown and the metabolism of those biofilms when you're initially starting a protocol or program that brings in some antimicrobials and biofilm busters. And so that showed up for me clinically when I first started using Bioside. I would have a patient start on the Bioside, and then they may have a completely discrete symptom as a result of starting it. An example I'll give you is that I'm treating someone with gastrointestinal dysbiosis. She started the Bioside, and she had a huge spike in anxiety, and I thought she was reacting to the Bioside, and I talked to Rachel, and she said, no, she's reacting to the biofilm breakdown. And the reason that happens is because those biofilms house more than just the microorganism that you're after, right? So say you're looking to work with Candida, and you're using Biocidin with that in your mind, you have to remember that you're also, if you're breaking up biofilms, dealing with oxalates and LPS and heavy metals, multiple organisms that the body may not even be in contact with because it's holed up behind a biofilm. So using a binding agent can be very, very helpful in compliance and in preventing that as you're working up on these products. So really important, 80% of all microbial infections develop biofilms. The teeth are the main site for that. Also implants will be a site of that as well. I'm going to talk a little bit about what Biocidin is. Once you learn what Biocidin is and its applications, then 60% of our line, 6 of the 10 products, have Biocidin in them. So Biocidin is a combination of 17 herbs and essential oils. So it has a number of different mechanisms. It was developed by Dr. Rachel Fresco over 30 years ago. So we have a long track record, clinical efficacy and safety. And the way that the product was developed is that Dr. Fresco was responding to a need in the Bay Area by doctors who were treating immune suppressed patients there. And it was developed in response to, or with the purpose of, helping those patients keep their pathogen load at bay. One of those doctors submitted Biocidin to Great Smokies Diagnostics, and the head of the lab called Rachel and said, I don't know who you are or what this is, but it's killing every pathogen that we have put it against. So in vitro, on over 250,000 stool samples, and that was, so Great Smokies is now Genova, so this is a ways back, but at that time Biocide was the most effective herbal antimicrobial that they tested, and you can see some of the microorganisms in vitro that showed sensitivity or a zone of inhibition to Biocide on over 250,000 stool samples: Klebsiella, Staph, Strep, Candida, Aspergillus. So some of those microorganisms familiar based on the conversation we've already had here. So that's exciting for us. The mechanisms of action for Biocidin are there are a few of them. So it's broad spectrum botanical. It has an antioxidant effect, very potent antioxidants, high in flavonoids and tannins. But the mechanism of action that we're going to focus on specifically today is that it has clearance of multiple classes of pathogens, it disrupts and dismantles biofilms, and it has this immunomodulatory effect as well. And we'll get to some research that we have on that. So the liquid, again, flagship product. It's easy to use because you can titrate the dosing. The capsules are the liquid, 5 drops of the liquid in a cap. And so same thing, except for now we all understand the importance of, I always use the liquid with my patients because otherwise you're missing one entire therapeutic area. You can treat the oral microbiome with this liquid, or you can work with the oral microbiome is what I should say. So Biocidin LSF now is the Biocidin in a liposomal form. So if you're looking for deeper tissue penetration, access to the blood and the lymphatics, then this would be the product that you would reach for. We do have research with Borrelia showing a 75% better intracellular absorption using the liposomal. So we have been able to document the movement of LSF inside the cell and across the tissue. So this would be, again, deeper acting. This is our biofilm research done in 2000. This is a pilot study done at the University of Binghamton in 2013. And the top graph you see there is Pseudomonas. Bottom graph is E. coli, both renowned for their biofilm activity. The top of Pseudomonas, one of them commonly implicated as well in SIBO, as well as E. coli. E. coli, the most common cause of chronic and acute cystitis as well. So you can see here that there was a total dismantling in 24 hours of the biofilms in vitro. So these are all different ways in which a biofilm establishes and maintains itself. The herbal or the botanicals that are in Biocidin have been shown in research to act in all of those ways. And we do have in our Borrelia research, again, we have been able to establish the effect of Biocidin on the efflux pump, that it disabled the efflux pump. And that's important because the efflux pump is one mechanism of antibiotic resistance. The efflux pump takes whatever it deems, whatever the cell decides might be dangerous to it, and pumps the efflux pump pushes it back outside of the cell. And if you disable that, then it loses its ability to resist antimicrobials, antibiotics, that sort of thing. And the immune system it can have a better activity potentially as well. This is research that was published for us about a year ago. The Biocidin throat spray is the product that was used in this research, and it was done on college athletes after a heavy workout, had have suppression of the secretory IgA. So in a double-blind placebo-controlled trial, we were able to see that after a single dose of the Biocidin throat spray, which is 3 pumps, there was a 66% increase in IgA in the oral mucosa. So really great research for us, and why we all carry this with us when we're traveling. The dental Sidon is our toothpaste. So this is 20% Biocidin liquid, additional nutrients for to assist in breath and healthy oral mucosa. That includes CoQ10 and quercetin. And actually, you know what? That's not correct. It's our next product that has CoQ10 and quercetin. But this is an easy way, again, for us to support our patients' oral health, to augment their oral hygiene, is to just replace their toothpaste with a toothpaste like this, and you'll be helping to modify their oral microbiome. The dental Sidon LS is the liposomal Biocidin. It has CoQ10 and quercetin, and because if you're looking to work with cavitations, root canals, periodontal disease, you're going to see better tissue penetration with a liposomal form. And so this would be more of a therapeutic level oral health product. So it's tastes good. It's a 2 or 3 pumps, rinse and spit. And so the two products are this one, the toothpaste, and the oral rinse. They can be used together. And I'll let you have a look at that on your own because I'm running low on time. So last thing I want to touch base on is the pilot study done by Dr. Rothschild. This is just one of the patients. He did 8 or 9 patients, and you can see a list. On this list, you're going to see a lot of the players that we've been talking about in oral health and systemic health. And what I love about this slide is it really illustrates what we've seen clinically, those of us practitioners who've been using this product line for years, how broad acting it is. So, you know, whether we know we're treating fungal or working with, if someone has a fungal overgrowth or if they had a bacterial overgrowth, whichever bacteria they had in the gut, I found myself using Biocidin. And so I was able to see clinically that it had this really broad activity, but now we've been able to illustrate that in this pilot study as well. I like the HPV and CMV are on there as well. This is the after testing for that patient. So down to 4 microorganisms from an initial 35. And this is, again, a similar illustration, and some of the microorganisms, this is sort of a compilation rather than a single individual, but you can see again on this list, Treponema and HPV and CMV before and after. Also, Porphyromonas, both endodontalis and gingivalis we saw them eradicated in this study as well. Here are slides that illustrate the before and after periodontal pocket after using the LSF Bioside, or the dental Sidon LS, excuse me. And then I'm going to leave you with this slideshow.
So here's a sample of plaque from a 6mm pocket, and you can see how active the bacteria is. And this patient has been irrigating a little bit. We've done perioscopy, we've done ozone, and it's still very active. So I took a sample from the same pocket and mixed it now with Biocidin, and you're going to see a different microbiome. So same pocket, just mixing it with Biocidin, and look at the difference in the microbiome. Biocidin is awesome. So I'm having the patient go home and do Biocidin in her pockets.
So I want to thank you for listening to the webinar today, and welcome you to listen in. I think it's tomorrow that we'll have another webinar on SIBO and SIFO and its relationship. There'll be some duplicated information, but hopefully mostly what you'll hear will be sort of a lead-in to a conversation on SIBO and SIFO tomorrow. I wish you all health and wellness and groundedness during this time, and thank you very much.